Welcome to Mind, Body, Health, and Politics. I'm your host, Dr. Richard Lewis Miller. Our guest today is Dr. Christopher Davis, coming to us all the way from Florida. Welcome to Mind, Body, Health, and Politics, Chris.
Well, thank you for having me. Thank you so much for having me. A pleasure to be here.
Now, what I didn't say in the introduction is that you are a prominent cardiologist, and we're going to be talking about all things cardiovascular today. I thought we'd begin by your giving us a description of the heart. The heart has 4 chambers. I'd like you to tell us about each of the chambers, what the name of the chamber is, what the function of that particular chamber is, and what kind of problems are associated with each of the chambers, and then wrap it up with interconnecting problems. Take it away. Chambers of the Heart with Dr. Chris Davis.
So if I get too in the weeds, you guys make sure you step in and say, "Oh, that's way too much detail." But I'll start with, so first of all, there are 4 chambers in the heart. So everybody has 4 chambers. There are 2 upper chambers of the heart, which are called the atria. So there's a left and a right atrium, and then there are 2 lower chambers of the heart called the ventricles, and there's a left and a right ventricle. So let's start with what we call the right side of the heart, okay, the right atrium and the right ventricle. The right side of the heart is where blood returns after it has been pumped out and goes to our muscles, and all the oxygen is extracted, and we're supplying the muscles. As the blood comes back in our venous system, the blood is pumped back into the right side of the heart through something called the vena cava. So the inferior and superior vena cava. So blood from the top of the body, from the head, comes in from the superior vena cava into the right atrium, and blood from the bottom of the lower extremities, the legs, comes in to the inferior vena cava into the right atrium. So it's kind of a dumping ground of that venous blood in the right atrium. So then there is a valve in between the right atrium and right ventricle called the tricuspid valve. Tricuspid meaning there are 3 cusps of that valve that actually opens and closes every time your heart beats. So it opens to let the blood out of that top chamber, right atrium, down into the right ventricle when that tricuspid valve opens. So some of the problems that can result in that particular interaction, if that valve doesn't function normally, if the valve is leaky, then blood from that bottom chamber, the right ventricle, can then go back up into the right atrium, and that's called tricuspid regurgitation. And so instead of that blood being pumped out normally where it would go from the right ventricle, it goes back up into the lungs, because remember, this is blood now that the oxygen has been removed. So now we have to reoxygenate. We have to put more oxygen back in that blood. And so it has to go from the right ventricle back into the lungs. So we basically pump from the right ventricle back into the lungs. But if that tricuspid valve doesn't work normally, it goes back up into the right atrium. So it's going into the wrong place. And then that kind of can back up into the rest of your system, into your veins. And a lot of times people develop what we call edema or swelling in their legs when the right side of the heart doesn't work normally. So if there's a leaky valve, or if the right ventricle is very large, then you can develop swelling or edema in those legs because there's leaking of the blood going in the wrong direction, back up into the right atrium and then back out into the venous system that causes that swelling. So as we now take the blood from the right ventricle back up into the lungs, again, there's another valve that goes in from the right ventricle to what we call the pulmonary arteries. Pulmonary meaning lung. So we're going from the ventricle, from the heart, back into the lung through the pulmonary arteries through a valve called the pulmonary valve or the pulmonic valve. That valve, again, can be dysfunctional in that it doesn't open normally or it doesn't close normally. And if that valve is leaky, again, the blood can leak back into the right ventricle. Or if it's stenotic, meaning it doesn't open all the way, that causes a lot of pressure, okay, in the right ventricle as well, because as the heart squeezes, as that right ventricle is squeezing, trying to get blood into the lung past the valve doesn't open, so that causes a lot of pressure on the right ventricle. And very similarly to what I described before, that can cause more backup of fluid into the right atrium and to the rest of the body that causes more edema or swelling as well when that valve doesn't open normally. So that's essentially what happens on the right side of the heart. And now we've taken the blood from the right side of the heart and we've kind of moved it to the right ventricle. And now we're in the lungs again. And as we are taking our breaths, deep breaths in and out, we're taking that oxygen from the air and actually going across the lung lining, the alveoli, and the blood is becoming reoxygenated. Okay. After the blood is reoxygenated, it has to now be emptied back into the heart, an oxygenated blood. And that oxygenated blood now comes back into the left side of the heart, the left atrium, the top chamber, into the left atrium through something called the pulmonic veins. So the pulmonic veins are now draining back into the left atrium. So now we have oxygenated blood, the blood that carries the oxygen that needs to go to our brains and to all of the other bodily parts, the muscles, is in the left atrium, and it has to go to the left ventricle, which is really the major muscle part of the heart. When we talk about our heart squeezing and the blood supply getting to the rest of our body, it's that left ventricle. When we talk about people who have heart failure, we're talking about the left ventricle being the part of the heart that squeezes and squeezes that blood to everywhere it needs to go. So we go from the left atrium into the left ventricle through a valve, again, called the mitral valve. That mitral valve opens and allows the blood to kind of come in from the left atrium down into the left ventricle. And then as that left ventricle squeezes, the blood has to gotta go out of the heart again through what's called the aortic valve to the rest of our body, to the brain, to the arms, to the legs, to the other organs, the liver. As that left ventricle squeezes, the aortic valve opens, the blood is able to go out into the rest of the body. Now, again, if these valves don't open and close normally, okay, for example, the mitral valve between the top chamber and bottom chamber, that doesn't open normally, that's called mitral stenosis. The valve doesn't open normally, so again, we get a back pressure or pressure buildup in the left atrium, which then builds up into the lungs, and that causes a host of problems, particularly heart failure symptoms, because now I have lots of fluid that's built up in the lungs because a valve didn't open normally. The mitral valve didn't open normally. Very similarly, if the valve is leaky, okay, the valve opens, but it doesn't close normally. So now every time that bottom chamber squeezes, every time that left ventricle squeezes, instead of it squeezing the blood where it's supposed to go, out of the aorta and into the rest of your body, across that aortic valve, that mitral valve becomes leaky and the blood is going back up into the left atrium again. So now again, we have more pressure, more volume build up in the left atrium, which then builds up in the lungs, which causes heart failure symptoms as well. So you can see that one of the things that causes heart failure, okay, it's not just the squeezing of the heart, but it's valves that don't open and close normally, which is a very, very common problem these days, between mitral valve and aortic valve being the most common. These are issues that people end up having a lot of trouble breathing with regard to heart failure type symptoms. Moving on again to the left ventricle out of the aorta across that aortic valve. The aortic valve is very commonly becomes what we call stenotic or calcified. The valve becomes calcified and doesn't open normally. I tell my patients a lot, the valve typically as the heart squeezes, it will open and close, open and close. Well, when that valve is doing this and not opening fully, again, the pressure in that bottom chamber of the heart, every time it squeezes, that pressure builds up in that left ventricle, which then causes more strain on the heart, more fluid buildup, and heart failure type symptoms. Other symptoms that can go with that are chest pain symptoms, passing out symptoms, lightheadedness, dizziness, because there's not enough blood supply going across the valve to supply the rest of your body. One of the other things, let's talk about just really quickly, arrhythmias or other heart disease. I didn't speak much about this, but all of these things that I described with the valves can end up causing issues with arrhythmias as well. One in particular that's very common, probably the most common rhythm problem that we have today is called atrial fibrillation. an irregular heartbeat that doesn't start in the typical place that the impulses start in the heart, but there are impulses kind of from all over the top chambers of the heart, the atria of the heart. And so there are lots of things that can contribute to the atrial fibrillation, but valvular heart disease is a major contributor to the atrial fibrillation. And I'm sure we can talk about the arrhythmias a little bit more in detail as we kind of move forward. So hopefully that wasn't too in detail, but the heart is a very complex organ, obviously. And needless to say, I didn't even get into some of the more, what I would like to say, some of the more important functions of the heart are not just that pumping capacity. The heart is really the seat of our emotions. And I would venture to say, I would even say the seat of consciousness. We can talk about that later if you choose to.
Okay. So you described the four chambers of the heart, and then you described, if I got it correctly, four different valves. You described a tricuspid valve, a pulmonary valve, a mitral valve, and an aortic valve, correct? Four valves. And the one that we in the public hear about the most often, I believe, is the aortic valve, correct? Now,
Correct.
is that because there are more issues that typically happen with human beings with the aortic valve than with the tricuspid, the pulmonary, and the mitrals?
I think that certainly we see more pathology results from the aortic valve. I think that the um, the number of people that have valvular heart disease, if we had to look at what type of valve is involved, the aortic valve is probably the most prominent valve. Um, I think that what goes with that, though, is we tend to think about what causes the valvular heart disease. And what we're learning, particularly about aortic stenosis, is some of the same risk factors for coronary artery disease, meaning blockages in the arteries, are also risk factors for the development and progression of aortic valve disease. And what do I mean by that? One of the markers that has been shown to be associated with aortic stenosis, and it's not talked about a lot, but the most recent A.C.C, American College of Cardiology, recommendations did mention a molecule called lipoprotein little a, which is a molecule, it's a type of cholesterol, okay, a specific type of LDL molecule that is associated with a higher risk of early heart disease, but it also is associated with a much higher risk of aortic stenosis. All right. Most of that LP little a is related to a genetic cause of it. And so there are no medications that can lower that lipoprotein little a. There's no specific diet that we know of that can lower lipoprotein little a, but we clearly know that it is a major contributor to the progression of aortic stenosis when the LP little a levels are elevated. So the answer to your question, yes, aortic stenosis is more common and it's more problematic with respect to symptoms that are related to it. There's a
Okay.
very classic triad
Now,
that I discussed earlier.
people are listening to this, and maybe some of them have a aortic valve stenosis. By the way, tell us briefly what a stenosis is, so everybody knows.
So stenosis just means a valve that doesn't open and close normally. It's a valve that, for example, again, the valve is a three-leaflet valve typically. So a tri-leaflet valve, the aortic valve is, and typically these leaflets, they open and close, kind of like I guess if you were just saying some type of gate, they open and close to let blood supply
Mm-hmm.
through those leaflets. Aortic stenosis typically is a calcific problem, meaning that those valve leaflets are fused together so that they don't open normally. So every time the heart squeezes, the blood has a difficult time getting across that area, getting across that area, because there's a very small opening as opposed to the normal size of the opening when those valves open, when the valve
Okay.
opens.
So we got the word that this is mostly a genetic issue. We're not going to cure this with exercise. We're not going to cure this with nutrition. We're not going to cure this with medication. However, there is a lot of hope because, as I understand it, we now have a relatively new procedure which is much less invasive called a transaortic valve replacement, a TAVR. So
Yep,
us
yep.
give us a little hope with the TAVR, so people who hear this and they say, "Oh my God, I've got one of these things they're talking about. The doctor told me I have an aortic stenosis. They're going to have to cut open my chest, or what's going to happen?"
Right. Absolutely. So let me go back and let me just clarify one thing. I think that there is some role for nutrition. I don't think you're going to reverse the aortic stenosis with nutrition, but I do think certainly that nutrition will play a role in preventing the progression or the rapidity of progression of the aortic stenosis over time. And what do I mean by that? Certainly, there's some evidence that abnormal oxidized LDL or cholesterol can play a role in the progression of aortic stenosis. Vitamin K deficiency, meaning that how our body uses vitamin D and metabolizes calcium. I said it was a disease of calcium buildup on those valves. Well, one of the things that's super important, and most people don't know this, or the doctors haven't talked about this, and I really want to make this point, is when we talk about calcification of valves and arteries, one of the most common culprits for that is the vitamin K2 deficiency. Vitamin K2 is what tells calcium where to go in the body. Calcium should be in our bones and teeth. When you have a vitamin K2 deficiency, calcium ends up in places that it shouldn't, i.e., the arteries and the valves. And that's something that I didn't even know as a cardiologist until late in my career and as I started to do more of a functional medicine cardiology approach. But I think it's really important that if you have calcification, make sure that your vitamin K2 levels are okay. Now, back to the TAVR question. So absolutely, one of the things that's come along in the last, I don't know now, probably 10 to 12 years, if not longer, is the ability to go in and replace a valve without having to open the chest. Okay, when we talk about an open heart surgery, before the only treatment we had for aortic valve with disease was an open heart surgery where we go in and we put in a pig valve or a mechanical valve to really put it in place of where your normal valve is to improve the blood supply across from the left ventricle into the aorta. Well, now we're able to actually do this procedure without having to actually have an open heart surgery, quote unquote. A lot of these procedures are done what we call a percutaneous approach. Percutaneous means through a catheter that's inserted most commonly in the groin, in the femoral artery. The femoral artery is kind of right in the groin area, right at the top of your leg. And we can go in with a catheter that goes up into your heart, and we use other imaging techniques like an echocardiogram, which is an ultrasound of the heart. So we can see the heart, we can see the valves, we can see where we're placing these valves. And so simultaneously, as we're advancing the valve into the correct place, we're watching it with ultrasound, and we can deploy, we can place a valve now percutaneously just by expanding a balloon in the aorta with a valve on basically a stented strut and open up a valve into that area. And now you have a valve that's been replaced without having to open the chest.
And you're able to take the old valve out?
So the old valve doesn't come out. The old valve is essentially just pressed against the
I
walls.
see. It stays.
Basically, yeah. So the valve stays. It's just compressed. Those valve leaflets are just compressed behind what we call the stent struts,
Okay.
or the metal plate part that actually holds the actual leaflets of the valve.
And is it accurate what we've heard that the new valve is often a pig valve from a pig?
Yeah. Yes, it is often.
And is that because we're able to receive a pig valve without rejecting it? The research.
So actually, it's very interesting that the pigs have a the anatomy of the heart in general of a pig is very similar to the human heart. In fact, I learned my first few years of training at the University of Virginia, my first heart catheterizations were actually cathing pigs because their anatomy is so similar to humans that I actually was doing research on pigs, but that research actually allowed me to do my first heart catheterizations on pigs. And yes, we can do these. They're treated in a way that they don't cause any type of reaction or immunologic reaction to the actual pig valves. No need for any type of immunosuppressive medications or anything of that nature when we do those.
Okay, now, as you were describing the anatomy of the heart, which you did very well and clearly, thank you, you mentioned an electrical problem that can happen, which you called afibrillation, which a lot of the public have heard about. It's referred to as AFib. And There are at least two kinds of AFib. There's a persistent AFib, and then there's a more of a in and out. I think it's called a paroxysmal AFib. And
Right.
so tell us a little more, since so many people have this. I've heard as much as a third of the population may be in AFib at any particular time. You can verify that. But tell us a little more about what happens when you have AFib and what are the various treatments. Take us through the ablation, the cardioversion, the medications. Give us a synopsis of that, please.
Right. All right. So yes, absolutely. Atrial fibrillation is actually a very common condition. Most of the time, atrial fibrillation is somewhat tough to detect at times because the most common symptom an individual will have are palpitations or heart fluttering. Now, heart fluttering or palpitations can be a number of things. It doesn't always mean that it's atrial fibrillation. Palpitations can be just extra heartbeats every now and then, or there are other arrhythmias or irregular heart beats that are, for example, supraventricular SVTs that are not necessarily atrial fibrillation. So the issue with atrial fibrillation is that it is associated with a higher risk of stroke because, as we talked about earlier, there are four chambers of the heart. The two top chambers are those atria. So atrial fibrillation is when those two top chambers, instead of squeezing normally, as they do, they are just kind of fibrillating. So they're kind of just quivering, as I would like to say. And so when the heart doesn't squeeze normally, when blood sits around and there's just a quivering of those two heart chambers, that blood is now stagnant in the top chambers of the heart. And so there's a much higher risk of clots forming as the blood is not being squeezed or mobilized when it's in the top chamber of the heart. So atrial fibrillation, the main consequence or the main risk that comes with that is the risk of stroke. There are other things as well, but that stroke risk is really what we are concerned about. Why it becomes tricky is because people can have atrial fibrillation, as you mentioned, that's what's called paroxysmal. It comes and goes. You can have atrial fibrillation one time and never have it again for another 5 or 6 years. You can have atrial fibrillation that one time and have it again 2 weeks later. You can have atrial fibrillation and it lasts for 10 minutes or it can last for 3 days. And there's no rhyme or reason to how long it lasts, when it's going to come back, and that's what makes it very tricky. It is also tricky because people will have atrial fibrillation. There is a subset of people who have atrial fibrillation and have no clue that they're in atrial fibrillation at all. Okay, there's a fair amount, and I can't give you a percentage, but there are a fair amount, and I would say up to 25% of people will have atrial fibrillation and never know that they
Okay,
have atrial fibrillation.
allow me to stop you with a question. If you're describing the AFib as a flutter, which means that less blood is being consistently pumped from those two upper chambers down into the ventricle, where you described from that left ventricle, it needs to be squeezed and pressed so that the oxygen is sent to the muscles all around the body. If there's only a flutter, then isn't less blood going into that left ventricle in order to be pumped out to the system? And if that's the case, I would think people would feel it immediately. They get tired because they don't have energy in their muscles. Tell us about that.
So absolutely, that thinking is absolutely correct. But the atrial contribution to how, meaning how the squeezing capacity or how much blood, the cardiac output, most of that cardiac output is determined by the squeezing of the bottom chambers, particularly the left ventricle. So, but there is some input of those top two chambers, the atrial chamber. So what ends up happening is the ventricle still squeezes. So say your average heart rate was 75 beats per minute when you're in a normal rhythm. Well, with atrial fibrillation, that heart rate could still be 75 beats per minute. However, it's very irregular, meaning instead of being beat, 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 atrial fibrillation is very irregular. Beat, 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 beat. So the beats per minute could still be about the same. So you can still get that same cardiac output. There could potentially be a small differential in the cardiac output with atrial fibrillation. That's more prominent if the heart already has weakness, meaning that it's more dependent on the atrial kick. Okay, that's called atrial kick when that top chamber squeezes. But really, when a heart is squeezing normally, for the most part, the bottom chambers, that atrial kick is not a huge part of the cardiac output. So in people who have a weak heart, yes. When you go into atrial fibrillation, you lose that atrial kick, and those people certainly will be more symptomatic. They will be more tired. They will be more short of breath. But it's not as common to actually feel that or see that when the overall heart is nice and strong and when the left ventricle is strong from the beginning. So you can see that sometimes, but it doesn't always happen. 90% of the time when the heart's squeezing normally, you don't feel that kind of necessarily that tiredness or weakness because the left ventricle can make up for it.
Well, this sounds like it could be scary to a lot of people who are hearing or reading what you're saying right now because they're thinking, oh my gosh, I could be having an AFib and not knowing it. In fact, I could be living with an AFib and not knowing it. But this doctor is saying that that could be dangerous.
I think that it's really important, and this is really, really important, that you absolutely could. And I think atrial fibrillation, we're seeing more and more and more of it. There are certain things that we know contribute to atrial fibrillation. Lifestyle certainly does contribute to it, meaning that too much caffeine, too much alcohol, exposure to EMF. These are things that we know increase the frequency of atrial fibrillation. Stress. All of us have a lot of stress these days. So we know that stress hormones, the higher the stress hormones or these catecholamines, what we call them, the risk of atrial fibrillation is higher. It is important if you have any symptoms that you think these ear palpitations, heart fluttering, heart beating fast. The other issue that I didn't mention, I think is really important that we talk about is that atrial fibrillation can end up with heart rates of 150, 180 beats per minute. If you ever wake up, okay, and your heart rate's 120, or you walk to your mailbox and your heart rate goes up to 130 for no reason, it's certainly something you need to think about, this atrial fibrillation, because the heart rate can be abnormally fast for no reason. So one of the ways you can tell if you are checking your heart rate and normally you're 60 or 70 and all of a sudden one morning you see it's 95 for no reason, definitely something you should talk to your doctor about because we should be thinking about, well, could I have some type of underlying rhythm problem? So that's one of the things everybody can do themselves. Just know what your heart rate is most of the time. And if you actually see that it's elevated, then you must consider atrial fibrillation.
Okay. When a person does what you're saying, they check in the morning, they notice that their heart rate is 120. That is what you cardiologists refer to as tachycardia. They've got it. Should they go to the emergency room? Should they call their doctor? How quickly should they take action when they read on some machine they're using, whether it's an autosphig or an oximeter? They see that their rate is way over 100. They're in a tachycardia. How quickly should they move?
So if you're noticing you're way over 100, then you should call your doctor immediately. Because remember, we talked about immediately, because there is a condition called tachycardia-mediated cardiomyopathy. Just big old words that means that if I let my heart beat at 140 beats a minute for too long, eventually it can't do that. So you develop a weakening of that heart muscle. So instead of squeezing normally and squeezing out 60% of the blood, which is kind of a normal, what we call ejection fraction, that heart muscle becomes weaker because now I've been beating at 140 or whatever, 130, 180 for hours, and the heart muscle starts to get weaker. And so it's important that you call your doctor immediately because there's some things that they could recommend. But also, more importantly, the diagnosis can be made on what it is. Getting into the doctor to figure out what it is. What you don't want to do is it beat for 140 and then it kind of changed back to a normal heartbeat. And we don't know what that was, but it wasn't normal. And that's when it becomes problematic because you have some type of arrhythmia that had you sought attention initially, we may have captured what that rhythm was. I have all of my patients, by the way, there's a little device you can get that hooks to your cell phone called a cardiomobile, so that if that ever happens to you, you put your fingers on your little device and it captures an EKG, so you'll know. And if say that rhythm breaks, so even if it breaks, we captured what it was, which is really what's important in figuring out, okay, what's going on with me. So that little device, particularly if this happens more than once or twice, going to Amazon and getting the cardiomobile is a wonderful adjunct to try to help make the diagnosis. And then you don't even need the doctor involved in that. You can at least record.
I wanted to underline something you said in red and have you come back to it, which is you said that caffeine and alcohol are contributors to AFib. Tell us a little about that, please, because those are two extremely common liquids that are taken in the United States?
Right, right. So one of the let's start with the caffeine. Caffeine, obviously, we know is a cardiovascular is a stimulant of the heart. And what we think about atrial fibrillation, a lot of what goes on with the heart there is a increase what we call sympathetic tone or more adrenaline or catecholamines that may drive the the normal heart rhythm starts in a place, an electrical circuit called the sinus node. Well, when the heart's overstimulated, you lose that ability of the heart, that normal generated impulse on the heart. And caffeine, we know, is a stimulant that can now cause us to have these impulses start to come from all over the heart, particularly in the top chambers of the heart. Most AFib and most of the ablations that are done, we think that the AFib results from the around the pulmonary veins. And remember, we talked about as the veins come back into the left atrium, right around where those veins come back in is where we think most of the electrical kind of, for lack of a better term, short circuits occur, and that's what triggers atrial fibrillation. Well, having these excess stimulants, which can cause the electrical circuits in the heart to go kind of haywire anyway, will trigger the higher risk of atrial fibrillation just from this increased stimulant. Alcohol, pretty much a similar thing. We know that alcohol.
One second.
Yes.
1 second, Chris, before we go to alcohol. Is there an amount of coffee or caffeine in tea and coffee that you tell your patients is allowable, or do you basically say if you've got AFib, you better cut out the caffeine completely?
Yeah, I mean, if you have AFib, I tell my patients they need to cut out the caffeine entirely. That's kind of that question is a little tough because I use a lot of genetics in my practice as well, and there's specific genes that help how well people will metabolize caffeine, and so some people are rapid caffeine metabolizers. And some people are very slow caffeine metabolizers. The rapid caffeine metabolizers, the data shows that they actually do a little bit better, meaning overall cardiovascular status wise, with a little bit of caffeine. But short of having these genetics on every patient, I tell patients that they should kind of abstain from the caffeine if you have AFib or any other arrhythmia, PVCs, for example. These are extra beats, these extra heartbeats that come from the bottom. A lot of times people will have palpitations and they're nothing more than these PVCs or premature ventricular contractions. One of the biggest things you can do is take the caffeine away and the PVCs go away. So other arrhythmias as well.
Thank you. Thank you. Okay, that's it, everybody. You heard it. You have an AFib, cut out the caffeine. Play it safe. Let's hear about alcohol.
So alcohol, similarly, what we know about alcohol, and people who are really abusing alcohol or drinking, 4 or 5 drinks a night, and when that's clearly abusing it, there is a condition that's actually, well, two things. There is a condition called holiday heart, which actually is people who are abusing alcohol develop atrial fibrillation after going on these binges of drinking. And then the other thing that typically can happen from alcohol is that alcohol also, irrespective of the atrial fibrillation, can cause this cardiomyopathy or weakened heart muscle. So as the heart muscle weakens, the heart becomes larger and larger and larger. And so you've probably heard about people having an enlarged heart. Well, as the heart geometry changes, okay, as that heart starts to remodel is what we call it. As that heart starts to remodel, the chances of atrial fibrillation are much higher as well, because the normal conduction pathways, the normal electrical circuits, are then kind of affected, or those are actually involved. As that heart starts to get bigger, the normal electrical circuits are compromised as well, which then triggers more atrial fibrillation.
So what do you say about alcohol? I know that Lancet published a study in 2017, a major longitudinal study in which their conclusion, the headline was, and then we're talking about well over 100,000 subjects, and I think over 1,000 scientists in that Lancet article. It was 2017. Their headline result for that study was, alcohol is toxic. Any amount of alcohol is toxic. Is that how you see it as a cardiologist? Is alcohol toxic to the heart?
Well, I think that I don't necessarily, we can go through all the literature on a glass of red wine. I think that I don't tell my patients that if somebody asks me about a glass of red wine, one a day or one every other day or so. I think there's some data with respect to the um, antioxidant effects that are in with the red wine that are reasonable to say, okay, let's think about from a cardiovascular perspective when we think about the Mediterranean diet, which these people did have a lot of, they had some red wine or wine in their diet. They had the best cardiovascular outcomes still. So I don't know that I would say it's yes, I think alcohol can be toxic, but do you have to abstain from alcohol 100%? I don't tell my patients that. I do say if you wanted to have a glass of red wine or say 5 glasses of red wine a week, I don't see that there is a problem with that unless you have AFib, unless you have a cardiomyopathy, unless you have some other reason that I think the benefit outweighs the risk. Okay. So I think there are some
Okay.
caveats there. I think definitely there are caveats. If you have underlying liver disease, okay, I'm not going to tell you to go out and drink any alcohol, right? So I think there's some other things you have to look at a more comprehensive assessment of the patient.
So if you're normal, in your opinion, you could have up to 5 glasses a week spread out. We're not talking about all five at once. However, if you're already suffering from AFib or you have a cardiomyopathy, then you're saying the best bet, lay off. Same
Absolutely.
with the caffeine,
Yep, yep, absolutely.
right?
100%. Yes.
Okay. Now that we've done sort of a basic anatomical and physical description of the heart, unless there's something you want to add, I'm now going to ask you some general questions. Um, One of the first ones will be, what are some of the determining factors, the big factors for you that determine how healthy a person's heart is going to be maintained?
So I'll start with just looking at as a cardiologist, most of my patients, I am able to look at the heart function with an echocardiogram, which is an ultrasound of the heart. The ultrasound lets me know how the valves are working. It lets me know how the heart's squeezing, making sure there are no anatomic abnormalities like holes in between chambers, which are called ASDs or atrial septal defect or ventral septal defect. Um, so looking at the heart is the first thing. The other things are looking at blood work is really important in giving me a really good assessment of what your cardiovascular risk is. And I want to be very clear about this, okay? Because I think this is something that any of your listeners, I would encourage every one of the listeners to take heed to this if you have not had this done. One, when we talk about blood work, heart disease is much more than cholesterol and cholesterol being elevated. And we have technology today and we have labs that are able to give us the type of cholesterol or the sizes of your cholesterol particles. We have markers that look at inflammation in the vessels. What is the chance that you have inflammation in your arteries of the heart? And when we talk about your risk of heart disease, I've had many people come to me having seen other doctors and they said, oh, your cholesterol is great and we don't have to worry about anything. But when we look deeper at the size of their cholesterol particles, when we look at the inflammation markers, when we look at some of the genetics, and hopefully we'll get to talk about a little bit of that, I think is really important and a little bit. But there are certain things that I can look at and see that there is a much higher risk of heart disease than just what I would presume if I looked at the standard traditional cholesterol, LDL, which is your bad cholesterol, HDL, good cholesterol, and triglycerides. So I would encourage you guys to everybody to ask for an advanced lipid panel with inflammation markers because the value of that from a predictive standpoint for cardiovascular disease is invaluable. In fact, I tell my patients now, I can't tell you about your risk of heart disease looking at a regular lipid panel.
Now, when you say inflammation markers, are you referring to things like C-reactive protein and homocysteine or others as well?
Others as well, but those are two important ones, the reactive protein. The major vascular inflammation marker is something called LPPLA2, lipoprotein phospholipase A2. That is a major vascular inflammation marker. Otherwise, in some testing, some companies call it plaque, PLAC testing. But the actual name of it is lipoprotein phospholipase A2. Other markers that we look at now are myeloperoxidase, um, other oxidative stress markers, F2 isoprostanes, and ADMA. Those are other, and really Quest has or Cleveland Heart that works with Quest now. They have a panel that really looks, their inflammation panel has all of these things there. I would encourage you, again, everybody to, if you wanted to go to Quest and just look up their inflammation or cardiovascular panel, it will have all of these things there. And at least once you should have these things. I mean, I don't think that you need to do it every single time, but I think that at least once, if you really want to know risk, I can tell you that I have patients that come, and if I run them through our standard our standard risk calculator, their risk has come out less than 4%. But when you look at the advanced lipid panel that I just told you about, there are multiple. I mean, I've had people that had severely high risk that I decided to move forward with other testing that had significant 60, 70% blockages in their coronary arteries, but you would not have picked that up with a basic lipid test.
Now, are these tests related to a test that I think you reference in one of your materials called the American Heart Association's Life Essential 8 checklist?
They are not a standard part of that. So that was an article that was written and just published recently that looked at the status of cardiovascular health in general. And it looked at this Essential 8 list, which looks at just your basic cholesterol panel. I'll tell you that, I have some issues with when you're looking, I always say this to my patients, if you're looking for the disease, you have to make sure you're looking in the right place. And so they're still looking at just your general cholesterol level, your total cholesterol level. There's much more to it than that, as I just mentioned. So that is something different. If I were to design looking at the cardiovascular risk, and I think that a lot of other cardiologists looking at that advanced lipid panel is much more informative than utilizing some of our standard high blood pressure, smoking. These things are important, absolutely. But the risk, looking at some of the genetics, looking at some of these other high risk markers, I spoke about lipoprotein little a earlier with aortic stenosis. This is another one. Tremendous is an independent risk factor for early heart disease. Lipoprotein little a, okay? Those are the people who are 30 and 40 years old that have a heart attack and you can't explain why. Those are all on that same panel that I just mentioned, the advanced lipid panel with the inflammatory markers. Homocysteine you mentioned, another really important one. We could talk about that for a long time as well. Not only inflammation, but the risk of stroke and heart attack with elevated homocysteine levels, that homocysteine, and I find that quite a bit. And the most common reason that homocysteine is elevated is because of a lack of B vitamins. B vitamins B2, B6, B9, B12. Okay, B9 being folate. And we do a really poor job and I have, again, in some of my presentations, I'll see that they say homocysteine's high, but nobody ever does anything about it. And it's very simple to address because it's typically B vitamin deficiencies. So the risk of heart disease or heart attacks, strokes, blood clots, pulmonary emboli, and DVT, if we were to address that homocysteine by improving B vitamin deficiencies, and it comes right down 90% of the time, that homocysteine would be normal, and those risks, or from a prevention standpoint, very simple things to achieve by improving the B vitamins.
In terms of direct recommendations, two things you've mentioned so far today are vitamin K2 and vitamin B2, 6, 9, and 12.
Mm-hmm. Yep. B complex. Most B6. I'm sorry. B complex. So B2, B6, B9, B12. And yes, the vitamin K2 particularly. This is something. If you're taking vitamin D, you should always be taking vitamin K2 with your vitamin D. Always.
What vitamins do you personally take every day?
Vitamin D. Now, I would say that if we look at the data, 90% of us could benefit from being on vitamin D and keeping those vitamin D levels on the higher side. So K2, D3, they typically come together, K2, D3. So your vitamin D product should be a K2, D3. Coenzyme Q10, I think, is very important for mitochondrial function. Mitochondria are what produces, I call them our battery packs. They are important for production of ATP or energy. And without CoQ10, that mitochondria cannot use carbohydrates or fatty acids to make energy. Um, I actually use a lot of other antioxidants, things like and I don't know that everybody needs this, but I use glutathione as a supplement. Glutathione is what we call Mother Nature's master antioxidant. I think we are all exposed to toxins in our environment, and some of it we just can't avoid. Your life is life, and we can't avoid the water and some of the stuff. I try to eat organic as much as I can, but some of this stuff that we can't avoid, I know if I'm giving my body back all of the antioxidants, it can fight off some of this oxidative stress. At the end of the day, every chronic illness that's out there, whether it's Alzheimer's disease, heart disease, diabetes, autoimmune, it revolves around inflammation and oxidative stress. And if we can address those inflammation and oxidative stress with things like glutathione, then we are ultimately, when we talk about our overall health and wellness, I know that I'm doing my patients and myself some good by adding those antioxidants. Um, Other anti-inflammatories I take, curcumin, again, a great anti-inflammatory that's a natural supplement. And fish oil. Fish oil, I think, is very, very, very important. A good quality fish oil. When we talk about brain health, when we talk about cardiovascular health, I think fish oil is a really big part of that.
Okay, so the doctor takes K2D3, CoQ10, glutathione, curcumin, and fish oil. Thank you. Thank you for sharing with us, because it's always important to know. I ask all my doctors that question. I tell all my patients, ask me anything about what I do. I'll tell you what I do, because you want to know not only what the person professes, but what they actually do in their life. So thank you. I appreciate your willingness to share that with us. Now, what are some of the other things that people hearing and reading, what are some of the other things they can do to improve the vitality of their heart?
Great, great. I think some of these things that I'll say, they're going to be improving the vitality of the heart, but just improving overall vitality. I think one of the things that I know we don't do a great job of emphasizing the importance of sleep. Uh, it is, I mean, the body doesn't rejuvenate itself. Your body can't heal without the appropriate deep REM sleep. I think that we've all talked about, yes, sleep is important, but we don't put enough emphasis on really what needs to happen and how much the sleep affects our regenerative capacity, our resilience to stress. Again, I'll go back to the point about in a world where we're all dealing with coronavirus and vaccines and illnesses and things of that nature, jobs and the economy and everything that's going on in our environment or our society these days, we're all exposed to stress. We can't I mean we and learning how to deal with that stress and learning how to have stress management techniques is really important. But a big part of that is getting adequate sleep. And I've seen now that I started to pay more attention to it in my personal life and in my patient's life with monitoring things. I use a lot of management of monitoring techniques like the Aura Ring or the Apple Watch or other BioStrap, other wearables allow me to look at something called heart rate variability, which is the autonomic nervous system, the balance of the autonomic nervous system. And that sleep plays a really important part in our overall resilience. How much am I able to deal with? How does my body respond to the stressors of the day, whether it's emotional stress, chemical stress, physical stress, whatever those stressors are? I want my body to be able to deal with those and respond to those as efficiently as possible. And sleep is a major part of that. Other things, water. I'm really a big proponent of clean water, meaning reverse osmosis systems, and then adding in some type of the other micronutrients that come back with it, or some of the minerals that can be added back in. One of the downsides of some of the reverse osmosis systems is, yes, they clean out all of the toxins and things like some of the fluorides, but they also take out a lot of the minerals that we need back. So I think it's important to kind of add that back. But really avoiding, in most places, avoiding tap water at all costs. that would be something else I would say to all of your listeners. Avoiding tap water, because today, invariably, there are lots of toxins in our water supply. Whether it's heavy metals, whether it's other chemicals. I do a lot of advanced testing looking at environmental toxins. And we see it. We can measure glyphosate. We can measure all these other levels of these elevated toxins. So really, clean water, I think, is also important. Nutrition, organic, eating organic. I can't tell you,
Hold
I
up.
wasn't a big believer until
Let
about
me interrupt. Thank you.
years ago.
Before you go into nutrition, which we definitely want to talk about, and exercise, of course, I want to talk a little bit more about water. What about people who have their own wells? Are you okay with them drinking their own water, which has not been contaminated, or is the very fact that it's coming out of the ground already mean it's already contaminated?
That's very, very tough. It depends on where you are. It really depends. I mean, I always ask my clients to find, and it's always tough because I don't know about, I mean, what type of companies and what are the good companies in, Maine or California. I have clients that are all over. So, but I do have them get the water tested because you don't. I mean, there's not a one size fits all. Unless you have water that's coming from a purified spring somewhere. I think that, and even then, I would still have my water tested. But well water in general, you should always. I can tell you cases of a couple that I had up in Maine who actually was on well water. They had some trouble selling their house because of what was in the well water, but they came to me. The lady had brain cancer. And in fact, one of the interesting things is I saw her husband because he was one of the guys that I told you he came from another cardiologist, and everything was okay. Everything looked great. But when I got labs, inflammation, all of those things that I mentioned to you, those were all very elevated. But the tip off to me was I also got heavy metals on him, and he had mercury and lead levels that were through the roof from this well. And so a lot of his heart disease revolved around, although all the tests were okay. But when you looked deeper into the risk factors, there was inflammation. And then when I looked for reasons for the inflammation, it was that same well water. So, I mean, I am very, very cautious. Anybody who comes in on well water, they're always getting their we're always getting that water tested. Now, unfortunately, depending on where you live, there may be no other choices for some people. It would mean actually getting water shipped in from some of the companies, particularly if you're drinking it. Sometimes you could use the well water for other things, and even then it's going to be absorbed. But certainly, I don't want to be consuming it orally if I have a lot of toxins or runoff. If I was in the Mississippi River Basin somewhere, absolutely no way would I use any type of well water. So there's some places I
Understood.
would say absolutely no.
Really depends on where you are.
Right.
Okay, let's talk about nutrition.
Absolutely. Well, that's a
Nutrition,
great one.
nutrition,
So nutrition.
nutrition and the heart.
So nutrition, I think that we are. I mean, I think we've neglected to talk about. We can talk to people about, but what should I eat? Well, in the cardiology realm, I remember for the first 10 years of my career, 15 years of my career, low fat diet, and lots of, obviously vegetables and stuff like that. But the low fat part is the thing that I think that I want to clarify that, because I don't think that we should be eating tons and tons and tons of saturated fat. But I think that's $1 million question, right? As a cardiologist, I'm gonna talk about this because it took me a long time to figure out, okay, where is the truth in my recommendations on what the diet should look like? What do I recommend for them to eat? Okay. And one of the things that we know that causes heart disease is metabolic syndrome or diabetes or insulin levels being high. And we know that we can eradicate this whole diabetes epidemic if we tell people to eat a low carbohydrate or even eating a higher fat diet. However, you have to be careful because there's not a one size fits all for diet. Okay, I'll say that this is the most important thing I think I can say. There's not a one size fits all. So when somebody says you should do a ketogenic diet, you should do a paleo diet, you should do a carnivore diet, okay? There's no one size fits all. So it's very important in knowing your there's a gene called ApoE. Every one of my clients, I recommend that they have an ApoE and know their ApoE status. Why is that? ApoE is what we call a high impact gene that's associated with a higher risk of stroke, heart attack, and dementia. Alzheimer's disease we have tons and tons of literature or studies out there that show the correlation with ApoE and a higher risk of dementia. Now, it doesn't mean that that causes dementia, but what we know about ApoE is that if you're eating a higher saturated fat diet, then the risk of the dementia, the risk of heart disease is much higher. What I saw in my patients before I started checking this on everybody is that when you put these people on a higher fat diet, those are the people, the cholesterol levels go extremely high. Their inflammation markers, all of the things that I discussed, the lipoprotein, phospholipase A2, and CRP, C-reactive protein, those things go through the roof when you put these people on a higher fat diet. So some people do extremely well on that higher fat diet. You can get rid of diabetes, the insulin resistance goes away or gets better. But if you're an ApoE status, then you're going to run into some trouble with that a lot of the time. And so what I do with those people is they're still on a low saturated fat diet, but we can then promote them having other types of healthy fats, avocado, olive oil. Those are different types of fat than a saturated fats, i.e. coconut oil. Is coconut oil good for you or bad for you? $1 million question, right? Some people say that coconut oil is great for you. Some people say that it's not. Well, the reason is there's not a one size fits all. If I'm an ApoE4 status, coconut oil is full of saturated fat, right? Grass-fed butter, is that good for me or bad for me? Well, $1 million question again. If I'm an ApoE4 status, I don't want to have a lot of coconut oil and ghee and grass-fed butter. We don't want to do those things. So understanding where and there's some other genes. I'm just taking this one gene here because I think that's super important for everybody to know. So that's one part of the nutrition. If we want to get to kind of the simple approach to nutrition, eat real food. What does that mean? Stay out of the processed food aisles in the middle. Eat organic vegetables. I don't feel like if we were to look at reversing heart disease, I think there's certainly some data on a plant-based diet, eating nothing but plants. But I do tell my clients that I meet everybody where they are. Okay, if you can't do that, I don't see the Mediterranean diet has shown over and over in the Lion Heart Study the benefits of the Mediterranean diet. Right. So a Mediterranean diet is a diet that is high in fruits and vegetables and fish. What I recommend most of the time, though, is a modified Mediterranean diet, meaning that limiting the grains in the diet. I think that one of the things we have to be very careful of are grains in our diet today. And that's one of the things that over and over, whole grains are a big part of things that are still recommended, but we have to be careful because the grains of today are not the grains of 40 years ago and 50 years ago. And there are tons of studies that have looked at the grains and the genetically modified grains causing more inflammation and affecting the gut microbiome. So I am a big believer in limiting grains and gluten, okay? And that's a whole nother subject in itself. I think that regardless of whether you're gluten sensitive or gluten allergic, everybody should limit the gluten in their diet. Everybody, every person. We could do a whole show on gluten and its the detrimental effects of gluten, but I've seen enough testing right now, advanced testing, to see that 90% of people are gluten sensitive, not necessarily allergic, not celiac disease, but most people are gluten sensitive, and that's causing more and more issues with gut microbiome and leaky gut. So, I mean, from a standpoint of general recommendations, gluten-free, eating lots of fresh fruit and vegetables, organic, as much as possible, and the quality of your meats is just as important. If you're going to eat, if you're eating fish, wild-caught fish. If you're eating beef, grass-fed and finished beef. Okay.
Now
So
you're doing something interesting now. You were very clear on no on gluten because of the implications, but you're now allowing for fish and meat and chicken. Now, are you allowing for fish and meat and chicken in what you'd call ordinary heart healthy people, or are you also allowing meat and chicken for people who are already suffering from some form of cardiovascular disease, such as a myopathy, an enlarged heart, a valve issue, an arrhythmia, it's congestion? What about for those folks? Because I do know, and please, I hope you'll verify, there appears to be somewhat of a controversy in your specialty of cardiology right now. And the controversy that I think I'm seeing is there are those who are focusing on the cholesterol and the fats as being cloggers of the system, which are causing big problems. And then there are others who are focusing on inflammation and saying inflammation is the big problem. When you get an inflammation, you get a little tiny hair sticking up or something inside a vessel, then stuff collects on it, and it's the inflammation that's the culprit. I'm guessing, as a person outside of cardiology, if it's either the fat, the cholesterol, or the inflammation, it's probably both. But what's your take on it?
I think it is. There's not there's not a one culprit. Okay, I can tell you that it is not cholesterol by itself. Okay, there are people with familial hyperlipidemia or cholesterols that are extremely high that don't develop heart disease. So if we use the concept that cholesterol is what causes heart disease, then most people everybody who has a cholesterol of 300 should have heart disease. But that's way, way, way far from the truth. But the cholesterol is important, and it's the type of cholesterol. Cholesterol, we said LDL and HDL. LDL comes in small, dense particles, and LDL comes in large, buoyant particles. They're also oxidized LDL, right? So that's an LDL molecule that's been oxidized. So that cholesterol is important because if it is oxidized and you have a lot of oxidative stress, then that does increase your risk of heart disease and the development of coronary disease. There's not a straightforward answer to that. I can tell you that it's not just cholesterol and it's not just inflammation. It's a combination of both of those. And at the end of the day, what you need to be doing is limiting the amount, anything that's causing more oxidative stress and inflammation. That's what you need to be avoiding, not just for your heart, but for brain, for every organ, for chronic disease in general. So that inflammation is very important, even more important when you have elevated cholesterol levels, which that inflammation ends up oxidizing your cholesterol and causing more oxidized LDL. So it's a combination of those things. You are right in that when we look at cardiology, there are programs out there that are very helpful. Dean Ornish program is a plant-based program with no oil at all, right? But there are other programs out there that are also Mediterranean diet style that do allow oils. So it could be very confusing even for the cardiologist. I mean, as a cardiologist, if you see my bookshelf behind me, I've kind of read all of those lines of thought. And where I land is there's no one size fits all. And you do have to look at, for example, I use a lot, again, I make my programs or my recommendations very individualized. If somebody has specific gene variants that tell me they're not going to deal with the saturated fat well, you're going to have more inflammation with the saturated fats, then I'm going to tell them, hey, you're going to probably do better on a plant-based diet. So I really am able to point in a direction based on genetics and epigenetics, meaning that how genes are expressed, as opposed to having a one-size-fits-all. That one-size-fits-all approach, you can see clearly why it can be very confusing because you have tons of different doctors and you have the schools of diabetes is another example. You have totally different schools of what you need to do to reverse the diabetes. So I don't think there's a one-size-fits-all, and that's where medicine needs to be more individualized for your patient.
Generally speaking, though, I understand and I really appreciate that you're avoiding and really taking a position to caution us against one size fits all. I very much appreciate and respect that position because generalizing to an individual person from normative data, as we know, it can actually be dangerous.
Absolutely.
It can be dangerous. So you have to learn what you're advocating for strongly is what I would hope all doctors would advocate for, which is looking at the patient right in front of you and treating that patient, of course, bringing to bear everything you know about normative data, but always looking at the specific person you have in front of you. Now, that said, do you eat meat and chicken and fish, and how much do you do it and how often?
So I'll be honest with you, again, being transparent, okay, I probably eat too much of those. What I'll say to you is
wait a minute. Hold on a second. Wait a minute. If you acknowledged here that you eat too much of those, then I only have as a colleague one word to say to you: stop.
I
stop.
No, no,
Change your behavior right away
I do.
because we need you to stick around. You're a
I
very
appreciate.
intelligent. You're making a big contribution to our field, and you're an important guy in that regard. So
Yeah, I
cut
100%
back.
agree. So let me tell you, I do think that hands down, when we look at longevity, not just heart disease, when we look at longevity, there's a book written by David Sinclair recently, and one of the things we know is that animal proteins, we really need to cut back. The lower animal protein diet is when people have the best longevity. When we look at all the different groups of people, from the Okinawans to all of these others, Sardinia, when we look at the people who live the longest, they have a relatively low animal protein diet, and I do think that there's a lot of science behind that right now. So if I had to tell you, not knowing any genetics, and I were to tell you where is the diet that is going to be safest for everybody, okay, I think that it is a diet that is loaded with whole foods, fruits, vegetables, limiting the refined things like breads and pastas, limiting the carbohydrates like white potatoes. We always talk about kind of the white things, the white potatoes. Um, Limiting eating things like sweet potatoes and summer squash for our carbohydrates. And with respect to the meat, if we're going to eat meat, really nothing more than a 4 ounces portion of a meat or chicken. And that's why I said I probably eat too much, because I'm typically more at an 8 ounce, probably double. So I'm again being transparent. The data, I'm telling you what the data says, and what the data says. If I were to go normatively and making a recommendation in general, it's limiting the amount of animal protein in the diet.
Now, we know that this prominent cardiovascular man that you referenced, David Sinclair, himself is quite a thin guy. So, what place does staying thin, keeping your weight low, what place does that have in this picture that we're painting of cardiovascular health and disease?
Huge, huge, and let me tell you why. It's not necessarily what comes with the weight thing and there's a book called Why We Get Fat, okay, and what makes us get fat. There's one major component that makes us get fat, and that's insulin levels being high or insulin resistance. So there's a book called The Obesity Code as well, okay? The Obesity Code talks about why we get fat. And insulin levels are high, and that's why people who have metabolic syndrome have heart disease. People who have diabetes have heart disease. So if you want to know one thing that makes you fat, it's insulin levels being high, or when I say fat, or overweight. Okay, so how does that play a role in when your weight's elevated? A lot of times, most of the time, there are people who can be overweight and have normal insulin levels. Okay, don't get me wrong, but a lot of times, most of the people who are particularly morbidly overweight, they are going to be insulin resistant people, and so insulin, we know, causes more coronary vascular disease, causes more eye problems, causes more kidney problems. So we're running into a host, causes more hypertension. One of the things that even most cardiologists don't realize, and I didn't realize, is that insulin plays a huge role in hypertension because it has a lot to do with sodium metabolism. So once we can reverse the insulin resistance, okay, your blood pressure comes right on down. And I've seen this now many, many, many times, that the problem is not, the problem is the insulin resistance, which is part of the metabolic syndrome. The problem is the insulin resistance is causing a lot of the hypertension. So once people start to bring down their insulin levels, so they have a much better metabolism of their sodium, and blood pressure comes right down as well. So as far as the weight thing goes, I think that definitely keeping your weight down, because that weight typically goes hand in hand with insulin resistance, and that insulin resistance or high insulin levels causes a lot of heart disease, a lot of other issues. So as we control our weight by becoming more insulin sensitive, I think the risk of other conditions improve as well.
Okay, we've talked about inflammation, we've talked about fat, we've talked about nutrition, we've talked about some of the vitamins that you recommend. Talk to us about the place of exercise and what levels of exercise for optimum cardio health.
Gotcha. I think that what I recommend for most of my patients, I'll tell you, the AHA American Heart Association, when you look at that life's essential eight, I think the recommendations as part of that to be considered at optimal was 150
That's right.
minutes of moderate exercise or 75 minutes of pretty significant exercise a week. I think that that's on the. We have to look at the spectrum of people that we're talking about first of all. But if I were to say in generalities, from the ages of 40 to 65, I think that I would. And again, I don't know of any data. I'll be honest with you. I encourage my patients to try to get at least. I'm a big believer in some of the high intensity, so getting the heart rate up and then kind of doing high intensity interval training for a cardiovascular perspective. So I typically will say 30 minutes, 5 days a week or so is what I typically recommend.
Now, realistically, Chris, are you saying 30 minutes, 5 days a week because you're attempting to be realistic about what your patients will actually do? Or are you saying 30 minutes because you think 30 minutes is sufficient? See, what I'm trying to get at here is if you had your druthers and you had compliant people who are going to listen to exactly what you tell them because you believe you know what's best, would you be recommending a different number? Would you be recommending zero meat? Would you be recommending zero alcohol? Would you be recommending zero caffeine? In other words, if you were looking at the ideal compliant patient who listens to everything and wants to do the best they can, A+ with Dr. Davis.
I would say the caffeine we talked about. I mean, I would say definitely. I mean, getting rid of the caffeine.
Cut out the caffeine.
The alcohol, I mean, it's very, when I talk about the polyphenols in red wine, the literature is there, okay? And when I say alcohol, it's hard because be honest with you, I'm not talking about other alcohols. I'm not talking about beer. I think that the data is with the polyphenols in the wine. So if we want to just say what I really believe,
yes, of course.
I'm a believer in the wine part. If I had to choose, the beer and other liquors, I don't mean those are not necessary. I'm not sure of the benefit, or has that been shown to be. I don't think that's been shown to be as beneficial as something like the polyphenols that we find in the red wine.
I don't know any benefit that's been shown from the beer and the hard spirits.
Yeah,
the only thing we've really seen is some possible benefit from the wine, and it's the red wine, right?
I agree. 100%.
The polyphenols and what they call resveratrol.
Resveratrol, right? Absolutely.
Yeah.
I would agree with that 100%. I think that as far as the exercise goes, I do think if you're doing I'm not talking about a 30-minute walk. I'm talking about a higher intensity where you're getting your heart rate up above, the 80, 85% brief, and 85% maximum heart rate or 90% maximum heart rate, bring it down and take it back up. I'm talking about a fairly aggressive exercise regimen. You don't need more than 30 minutes a day. Okay. If you're walking,
if you're fairly aggressive, meaning staying within what Ken Cooper called the aerobic space between 60 and 80% of max heart for 30 minutes.
So somewhere, yes. Now, I don't mean like taking a stroll and, if you walk for 30 minutes and your heart rate doesn't get above, your maximum heart rate. So let's just say your baseline heart rate is 70 and you're taking your heart rate to, 80 or 84, then you're not, that's not a cardiovascular workout that you're really kind of building up any type of improvement in the overall.
So for the heart, taking a walk is not beneficial particularly.
No,
it's something.
No. I won't say it's not beneficial. We have to be careful here because movement, even people getting out to take a walk, and in today's society when people are sitting around on their bum all day, even getting out to take a walk is more than what we're doing before. So
it's more than nothing.
If you're going to get up and take a walk and you were doing nothing, I'm happy with you. I'm clapping my hands. I'm happy with you. Okay? Now, is that optimal and where I would want you to be? No. But we have to realize where you're starting from, right? Every single person we talked about, is an individual. If this is an individual who sits around on a couch and eats Cheetos all day, then him getting up to take a walk or her getting up to take a walk is a major improvement. So I think that again, that should be really
Yeah,
individual. My
you have
workout,
to.
and yeah, we really have to individualize the workouts too. I think that's really important.
I see. Yeah, you have to take the patient where they're starting from, and given what you know about the American condition, even getting off the couch and walking across the room to the refrigerator is better than having it delivered.
Good point. Good point.
Well, I
Absolutely.
want to be respectful of your time. I hope you'll come back. This has been a very educational interview. There's a lot of wonderful information that we're going to get out to the public, and I thank you very much.
My pleasure. Always a pleasure to be with you, and I'd be happy to come back. Thank you.